Well, good evening, Susan. Thank you for that introduction. And hey, everybody, welcome to my house tonight from Clearwater, Florida. So hopefully you're living somewhere where you're having some nice weather like we are. It's been a beautiful day down here. So for this evening, we're going to talk a little bit here, but a sponsored talk by Zomedica, and basically talk about some newer tests that are now available to be run that would fall under the terms gastrointestinal blood panels. And here you see a little Henri, a French bulldog, and maybe it's just a specialist in me, but when I look at poor little Henri, and especially when I look at his behind, he's got no butt. And that would be a big indication for me to wonder, does this dog have gastrointestinal disease? No, I'm actually only kidding you guys. I wouldn't think of that. So for you guys that are familiar with me, welcome back. For people that are not, I'm from Tampa Bay Veterinary Internal Medicine. I also do a lot of speaking, both at the University at Colorado State for international vet seminars. I work for a number of different companies. My email is on this slide, so if you take a photo of that, you are welcome anytime to certainly inquire if you have questions. I'm an Ohio State guy from both undergrad and veterinary school, and Colorado State residency trained. So tonight, we always do financial disclosures, and I have to admit this is a commercial talk this evening. I do have a relationship with Zomedica, hopefully a good one, and hopefully by the end tonight, it'll still be a good one. But I really enjoy partnering with this company. They've got some really interesting things, and we're going to talk primarily about their Truforma, which is a in-clinic diagnostic platform that can both look at gastrointestinal blood tests as well as endocrine tests, as you'll see a little bit later tonight. So, guys, to start you off, when I was a young resident in my first few years in private practice, we saw so many patients with chronic enteropathies or chronic gastrointestinal disorders. And, they all, when we worked them up, we had a very standard workup we did. We scoped and biopsied almost all of these dogs and cats that had, consistent appetite changes, diarrhea, vomiting, weight and condition loss. And almost always our histopathology came back the same. There was some inflammatory mucosal or mural infiltrate, usually lymphocytic, plasmacytic. The only thing that ever seemed to change was whether the pathologist called it mild, moderate, or severe. There was always some architectural changes to the gut, some villi that were atrophied or fused, varying degrees of fibrosis, and so on. And almost all of those patients then got called inflammatory bowel disease, IBD, and they were all treated with immunosuppressive therapies to quite varying success. Some did really well, and some we just crashed and burned. We've gotten a bit smarter now, and we've changed the terminology for this disorder. We now recognize it's not just one thing. It's not inflammatory bowel disease. These patients, especially that have chronic issues, are better served with the term chronic enteropathy, or CE. And again, those patients all have varying degrees of clinical signs. They have the same type of patterns. If you biopsy them, there'll be inflammation and architectural changes to their intestinal tract. But what separates them is that they basically are separate diseases that all have similar signs and histopath findings. So again, CE is sort of an umbrella term, as you see here. And again, our therapeutic response to different treatments will tell us which disease that they have. So again, IBD is not the catch-all term anymore. Chronic enteropathy is. So there's a number of papers in the last 5 years that have been out that have talked pretty extensively, especially in dogs and some in cats as well, about these chronic enteropathy categories. Here you see a Shar-Pei that certainly something doesn't look normal there coming out of that back end. But when we look at this umbrella term of chronic enteropathies, about half of it are food responsive disorders. If you can find the right food, whether that be a low fat food in dogs, whether it be a high protein, low carb food in cats, whether it's hypoallergenic, whether it is a hydrolyzed diet, 50% of these cases will fall into a positive response to food. So the first take home from tonight is you really have to try hard on patients, especially if they're younger to middle age, they're relatively stable but have chronic GI signs. Remember that half of those patients will likely respond to food if you and the owner are diligent and patient enough to get them through food trials. Now, what about the other half? That's where we're going to spend more time this evening. About another 25 or so percent of those patients would be considered microbiome responsive, meaning, again, they have dysbiosis. There's some imbalance or some change in their microflora of the GI tract that's causing these clinical signs and these inflammatory responses. Smaller percentages then can have low vitamin B12 levels. There are some that, again, are low in cortisol, so our Addison's type patients. We certainly have plenty of them that have pancreatic disease, either insufficiencies like TLI patients, exocrine pancreatic insufficiencies, or chronic pancreatitis. We see some that are the true inflammatory bowel disease that would respond to trials with immunosuppressive drugs. And then another portion of them can be cancer patients. And then lastly, specific infections, parasites, fungal infections, and so on. So again, it would certainly be nice in these patients if we had some sort of way to differentiate these diseases in a fairly rapid way, maybe in our own practices. And the good news is we can by doing these gastrointestinal panels. So what are gastrointestinal panels? They would be, from a blood standpoint, running tests like PL levels, pancreatic lipase, and trypsin-like immunoreactivity. They would be looking at cortisol levels. They would be looking at cobalamin, specifically for cobalamin deficiencies. We could look at serum folate levels to give us some insight into the microbiome. And then lastly, if we wanted to submit feces, this is something you can't really do in your own hospital, but you can submit feces to a laboratory that can do PCR testing and help you and determine whether a patient has a microbial imbalance. So again, these are just a list of boxes that you certainly could check. And in the older days, we would send these panels off to a laboratory that could run these specific things. One thing we always say is just because you can check a box doesn't mean that you should. But when it comes to patients with chronic GI disorders, and we'll also have some select acute disorders we'll talk about tonight, all of these 5 blood tests make sense for you as a practitioner to have a good idea what they are before you start getting into in-depth things like biopsy of the intestine, maybe before you get into in-depth things like immunosuppressive therapy trials and so forth. So again, it's not difficult to do at all. So what is a GI blood panel? A GI blood panel, and who's it indicated in? Indications are any of these patients that either have chronic hyporexia, changes in appetite, dysrexia, diarrhea, and vomiting. Those would be the number 1 and 2 clinical signs. Certainly most of them experience some weight loss or at least some changes in body condition that become recognizable. Most of these patients have sort of slow, insidious signs that can progress over time. If you see patients with real rapid progression of clinical signs, then it might become more important to accelerate a workup and maybe think biopsies would be more important, especially if they're older patients that might fit more into a cancer type profile. The preparation for GI blood samples are simple. It's a simple 12-hour fast. And because many of these patients, of course, have GI disease, most of them are pretty willing to do that fast pretty easily for you. We're going to simply collect a serum sample, and we can run, again, these tests based on that. Now, again, why are these important? Because with a single serum sample, if we run these 5 types of tests, look at the things we can diagnose. A big portion of that umbrella for chronic enteropathy. And we can think about things like cobalamin deficiency, Addison's disease, dysbiosis. We might be able to regionalize disease into the proximal intestine, which you'll see in a little bit, versus distal intestine. We can look at the pancreas specifically for its exocrine function and look for exocrine pancreatic insufficiency. And we can also look for pancreatitis. So a pretty powerful set of potential diagnostic rule-outs all can come from that simple blood test. Again, in the past, we would send that out, but now we will have the ability to go ahead and run those in-house. Let me see if I can back up a slide for you there. There you go. Yeah. Okay. So let's take a look at the test individually and see what the power of them are. And again, what you'll be thinking when you run those, and a little bit about therapy tonight as well, since we want to make this a practical talk, but not all just about, hey, you can run a blood sample. What are we going to do with those results? So let's tackle cobalamin first. I think that's probably one of the biggest things that you really want to know your patient's cobalamin status anytime they have a chronic gastrointestinal disorder. Again, vitamin B12 is a water-soluble vitamin. Dogs and cats cannot synthesize it on their own. They are reliant on dietary intake. And not only do they have to, of course, take it in, but it's got to be absorbed into the body to be effective. It's got a pretty complicated pathway to get into the body. Once you eat vitamin B12, the stomach complexes it with what's called hepatocorrin, which basically gets it through the acid environment of the stomach without being destroyed. It's then traded off in the intestine into something in complex with intrinsic factor, which can then again carry it to the specific cobalamin receptors, which are located in the distal ileum. And again, deficiencies are thus very common when we have any kind of either diffuse intestinal disease, selective distal intestinal disease, meaning ileal involvement, or pancreatic disease, because intrinsic factor is made by the pancreas. So again, you've got to have a healthy pancreas in order to get this vitamin B12 complexed and taken into the system. Vitamin B12 is essential. It's a big thing. Almost every metabolic pathway in your body utilizes vitamin B12 to be effective. So both for any kind of nucleic acid synthesis, citric acid cycle. So bottom line is energy relies on vitamin B12. Now, I'll leave it up to you guys as a group, but we could sit here and go through the Krebs cycle for the next couple of hours and tell you all the different places cobalamin acts there, but I think we probably shouldn't do that. If you wanted a much more detailed idea about cobalamin, there's a couple of recent reviews for dogs and cats that you've got here from papers from ACVIM and in the Animal Journal as well. So some really nice comprehensive discussions of what vitamin B12 does once it's in the body. All right, so we're interested in low cobalamin levels or hypocobalaminemia. And what are the causes for this? Well, we've already stated, because the way vitamin B12 has to be ingested, carried through the intestines, and absorbed properly in the ileum, any type of chronic gastrointestinal problem or pancreatic problem will relate in low vitamin B12 levels potentially. They could be your food responsive enteropathies that we said are 50% of chronic enteropathies. They could be simple things like intestinal parasites. They can be inflammatory bowel disease. They can be neoplasia. They can be dysbiosis, anything that leads to disruption or differences in your genuses of or species of bacteria in the intestines will potentially throw off vitamin B12. Actually, some of those bacteria compete with the body because they use vitamin B12 as well. So any chronic gastrointestinal or pancreatic disorder can result commonly in hypocobalaminemia. So can exocrine pancreatic insufficiency. Anytime you have that disease, you are lacking intrinsic factor. You won't carry the molecule properly through the intestines to its ileal absorption site. Hereditary cobalamin malabsorption is something that a lot of us don't think about, but there are specific breeds of both dogs and cats. These are breeds where it's been proven to be an issue, that you can be born with several different disorders, but bottom line is you cannot maintain tissue levels of cobalamin. And those are patients, border collies, giant schnauzers, Shar-Peis, beagles, Aussie shepherds, Yorkies, and whatever the heck Komondors are. I'd have to go look that picture up to see. I thought those were the big birds that were out there in California, but I guess there's dogs as well. As far as breeds, we haven't proven it, but we see increased numbers. German Shepherds, of course, Greyhounds, Staffordshire Bull Terriers, at least specifically in the United Kingdom, and in cats, it's Siamese. A last thing that can create hypocobalaminemia if you're eating an exclusive vegetarian or vegan diet, you want to watch your vitamin levels carefully because, again, vitamin B12 oftentimes is a constituent in muscle and meat protein products that are in dog and cat and people's foods. All right, so clinical signs of low cobalamin, again, it can certainly look like any other GI disorder. Affects your appetite, loose stool, weight loss. We see this failure to thrive, especially in some of these patients that have the hereditary forms. They may have immunodeficiencies. We can see specific neuropathies affecting both the central nervous system and the peripheral nervous system, non-regenerative anemia, sometimes neutropenias and hypoglycemia, hyperammonemia. So patient looks like a shunt, but it's not a shunt. Sometimes can be vitamin B12 deficient. And again, it's some of the specific amino acid alterations. There's our specific Siamese cat. This is a Shar-Pei, of course, that I don't know about you guys as veterinarians, but tell you a brief little story. You probably don't ever want to tell your neighbors what you do, right? Because then they come over, they have free reign to grab free consults whenever they like. I used to come home every night and see this little Shar-Pei, and I thought, my goodness, that poor guy must have cancer. He looks so horrible being walked by his owner. One night, that owner showed up in my garage with their dog, and they said, "Are you a veterinarian?" And I wanted to say, "No, I am not." But of course, the call to duty, I said, "Yes, I'm actually an internist. What's the matter with your dog?" And she said, "My dog's only 6 months old." I was like, wow. Of course, we went ahead and did a GI panel, and this was a patient that had congenital hereditary cobalamin deficiency. And within a couple of weeks, he looked great, looked like a normal, 6 to 8 month old puppy. So don't ever forget that these congenital diseases sometimes can be vitamin B12 related as well. The bottom important thing that you guys need to know, and I think sometimes gets overlooked, is regardless of what the cause of vitamin B12 deficiency is, whether it's GI disease, whether it's pancreatic disease, hereditary, a vegan type diet, unless you diagnose this and treat it, patients are not going to get better. For example, you might have hookworms and develop vitamin B12 deficiency. You give the patient deworming medication and they get a suboptimal response. They don't get 100% better. Why? Maybe because we did not look to see what our cobalamin level is. So even simple diseases can be rendered more difficult to treat if we're not aware of that point. So here's something I think is really important to look at. This is looking at serum cobalamin determinations. How do you do it? In the older days, as of meaning 2024 and before, we had to send it to a reference laboratory where they can do an automated chemilucence assay. Those are the ones you see at Texas A&M GI Lab or IDEX or Antech reference laboratories. The machine we're here to talk to you about a little bit tonight, the Truforma machine, and we'll speak about that in more detail later, is a point-of-care machine. It can be done in your hospital now as of this year. You can run both cobalamin and folate levels and get results within 15 minutes. So very nice machine to have. Bottom line becomes, when we do a cobalamin level in a patient with GI signs or some of the other signs we mentioned, we know that if you, basically all labs are a little different, but they're pretty close to these reference intervals. If you have a reference interval where you're between 250 and 1,000 nanograms per liter, we would consider that normal cobalamin. That would probably tell us that, again, low cobalamin is not our issue. If we get down between 150 and 250, that would be low hypocobalamin, and less than 150 is we are definitely tissue deficient. And we, definitely are thinking our signs in many of these cases are going to be due to cobalamin deficiency. So what do we consider a critical cutoff for treatment? Who do we look at and say, hey, they would probably benefit from cobalamin? It's patients that are under 400 nanograms per liter. So if you're in the lower 25% of the reference interval, we recommend supplementation. Because again, we don't want you to get all the way down to the point where you're cobalamin deficient. So if you're in that lower 25%, less than 400 nanograms per liter, we think those are patients that should receive cobalamin supplementation. You can do it just like we've always done it, either parenterally by sub-Q injection. Again, you can see the dose ranges depending on the size of the cat or dog listed to your left side. And basically, we're going to give an injection weekly for 6 weeks. If you want to know that your therapy has been effective, you would see two things. One would be improvement in clinical signs. Again, for tonight's talk, we'd be looking for better appetite, less vomiting, definitely less diarrhea, more formed stool, hopefully putting some weight back on. If you wanted to prove that you have given enough cobalamin to this patient, you would then go ahead and basically, after your 6 weeks of injections are done, you would stop for a month, and on week 10, you would recheck your serum cobalamin level. And if you have basically found a reason for GI disease and resolve that, and your cobalamin level is still in the upper ends of the normal range or above normal, that tells you you have been successful in your management. If you have a disease that you can't identify, or the patient has congenital hypocobalaminaemia, in these patients, we're going to continue to treat them. We fear if we don't, they'll fall back into low cobalamin. So again, you could continue injections either every 2 to 4 weeks. And that would probably become lifelong for those patients. We also know in the last couple of years that some clients, I prefer injections. I think once a week injection is preferable for me. But some patients and clients, actually, not so much patients, want to give oral daily vitamin B12 at home. You can do it. I would be careful here that I would probably only consider the use of one brand, and that would be Cobalaquin from Nutramax. That's been the only one that's been validated to be bioavailable and appropriately absorbed in dogs and cats. Again, you can see the dose ranges. You would give a daily vitamin supplement orally to them. And we would give it, again, if we were trying to prove, we want to go at least a 12-week course of therapy to see if their clinical signs improve on the oral. It may take a little longer. And then if we wanted to show that we did raise their blood levels, we would take 1 week off. So then on week 13, we would recheck their cobalamin level. Again, it should be in the high normal or above the normal range. Again, if you are a congenital case or a chronic GI case and something that you can't cure, you're going to continue on that daily dose, probably forever. So again, pretty simple and relatively inexpensive disease to treat. The key thing here, guys, though, you have to look for it. You have to run this test to know that it's there. Now, what about vitamin B12? Vitamin B9, folate levels. So again, we tend to run these two vitamin tests together when we're assessing intestinal function. Vitamin B9 or folates contained in a wide variety of foods, not just protein-based. They can be both in vegetables and liver, dairy, meat products. It can also be produced by intestinal bacteria, where again, vitamin B12, cobalamin, was not. It's only absorbed in the proximal small intestine, so mostly the duodenum, and maybe the first 25% at most of the jejunum. So this is a vitamin that, again, upper intestine, where cobalamin was ileum, lower intestine. It's got limited stability at room temperature. So again, you always want to be careful to make sure samples, if you're sending them out, are sent out chilled. The nice thing, again, nowadays, you can do this as a point of care on the only test platform that does it, the Zomedica Truforma. You can see reference ranges are fairly well established for dogs and cats, basically somewhere around 10 up to the low 20s micrograms per liter would be considered normal serum vitamin B9 or folate levels. So how do we use folate? We use folate basically, most importantly, we're looking for either elevation or decreases. Elevation would be consistent with too much folate being produced, because you can't eat too much folate, impossible. You would basically have bacteria within your intestinal tract that are excessively producing it, and that would be consistent with the term dysbiosis. Again, you probably now have an overabundance of a specific bacteria that's doing this. And again, we would thus, if we identify a high folate, we would treat a patient for dysbiosis through a variety of means, right? Diet changes. We could certainly go ahead and consider probiotics. We could certainly consider fecal microbial transplants. The big thing we don't want to do any longer is to give them antibiotics like metronidazole or Tylan, as those things, those antibiotics can further progress their dysbiosis. So that's the key with elevated folate. It tells you the bacteria is off in the upper intestine. It's likely the cause of your patient's signs. Let's go ahead and work on their microbiome. Now, low serum folates are important as well. If you don't have enough folate in your system, that tells us there's a block. There's a block in absorbing it, because we always know you're taking in enough. between your bacteria and what you're eating, you're never going to be dietary deficient. So this suggests that there's some infiltrative block, if you will, in the upper intestine, so probably your duodenum or jejunum. So it gives you a place to consider looking: ultrasound exam, endoscopy, biopsy, to see if we can further define what the cause of that low serum folate would be. And of course, we would go ahead then and treat that appropriately, and then hopefully your folate level comes back up. Does low folate cause disease? Is there a need for us to supplement it in these patients that we find with upper intestinal disease? Should we be doing that? The answer is somewhat unclear. In dogs and cats, we really don't think that there's a lot of things that are a problem associated with low folate or hypofolate. In people, they certainly can see more hematologic red blood cell disorders and immunodeficiencies. We haven't documented much of that in veterinary medicine. So the question really becomes, if you have a low folate, is it really necessary to supplement it? It's probably more important, of course, to identify and take care of the underlying upper GI issue. If you do that, your folate levels will likely climb back to normal very quickly. If, however, a patient was anemic, just a really poor doer, I wouldn't hesitate to give temporary folate supplementation until you correct whatever the underlying issue is. Supplementation is safe and it's inexpensive. You can use over-the-counter folic acid. They usually come in 400 microgram tablets. Smaller individuals would take a 200 microgram dose once a day. Individuals over 20 kilograms, larger dogs, would take 400 micrograms once a day. Probably a 30-day length of therapy would be adequate. That gives you time, again, to identify the underlying cause and hopefully reverse that. And again, I tend not to go back and recheck folate levels unless the case just is not doing properly. Again, it's questionable how really intently we have to worry about supplementing this vitamin. Okay, so those are your two vitamins of concern in a GI panel. Let's look at cortisol. Cortisol, again, gets overlooked, I think, a lot as to its importance in chronic GI disease. It has a big role, although we really don't know exactly what the role or why glucocorticoids are needed for gastrointestinal homeostasis. But we know if you don't have enough glucocorticoids, you get lack of appetite, you vomit, you get diarrhea, you can get gastrointestinal ulcerations, you can get weight loss. All of those things are associated with Addison's disease, whether it's typical or atypical. When you have lack of glucocorticoids, as you can see with our destruction algorithm here on the zona fasciculata of the adrenal cortex, and our cortisol levels drop. If it's isolated to a glucocorticoid deficiency only, those are the tougher cases. I think we would all agree that typical Addison's is pretty easy to suspect because of the electrolyte imbalances and the rapid, acute, shocky nature of most of those patients. It's these ones that only destroy the zona fasciculata and get glucocorticoid isolated deficiencies. Again, we'll call that atypical Addison's. Those are the ones that have these GI signs that just sort of wax and wane, and sometimes you give them a little bit of supportive fluids or supportive care with anything, and they get better for a while. So it can very much mimic any other form of chronic enteropathy. And again, I think it's something we overlook or don't consider often enough, that we would like to know in anybody with GI issues, do they have appropriate levels of cortisol? So the gold standard diagnostic test is still the ACTH stimulation test. I'm guessing that most of you maybe don't carry ACTH in your clinics. I know most of my referring vets do not, and you're looking to refer cases out for that test. Again, certainly that's the best way to tell whether a patient truly has any cortisol reserve or whether they truly have Addison's disease. Fair amount of cost involved to it. It requires 2 samples. So again, while it's the best test to run, from a practical standpoint, we just don't always do it. So if you're stuck with a patient that basically has suspicion, GI disease, and you have suspicion of low cortisol levels, what can you do in practice right now, today, that could maybe help you with this diagnosis or ruling it out? I mean, it's nice to know if you have Addison's, but it's also nice to know if we can take it off the rule out list, right? So bottom line is, if you can run a serum cortisol level in your practice, which on the Truforma platform and other platforms you can, we can get a result back within a few minutes. And if that result is less than 2 micrograms per deciliter, or if you're up at Auburn in Alabama, 55 nanomoles per liter, by itself, that low resting cortisol does not confirm hypoadrenocorticism, because again, it doesn't tell you anything about reserve capacity to the adrenal gland. And healthy dogs and sick dogs that are non-Addisonian have fluctuation in their daily cortisol levels. So the specificity is very poor, especially if you have normal electrolytes, meaning there's lots of false positives when you have a cortisol below 2.0. And again, you would have to do an ACTH to confirm that. Now, what about if you have a cortisol that's above 2.0 micrograms per DL or above 55 nanomoles per liter? That effectively can rule out Addison's disease for you immediately. It's 99% sensitive, so there just aren't false negatives. We can rule it out. So if we looked at it on a graph here, you see over on the left side of this graph, let me see if I can get us on here. There we go. Your patients that truly have hypoadrenocorticism, all of them have cortisols that are less than generally 1 for most true Addisonians. But notice that non-adrenal illnesses or healthy patients are all over the place, including some that are low. But where do you not see any patients? Right up here in this area. And why is that? It's because anybody who's got a cortisol of over 2 micrograms per DL, they can't be Addisonian based on statistics. So again, we can rule it out very, very easily. But hey, just for fun, what if you said, great, that's good to rule out patients, but now if I have a patient with a cortisol less than 2, do I have to send that patient for referral now to do an ACTH to prove this disease? I mean, that is the gold standard test. But if you have a Truforma platform, you can also consider then running a plasma ACTH level. This platform is the only machine that can run that in-house for you. Otherwise, you would have to send that out. And basically, without getting too deep in the weeds about this type of testing, if you ran a simultaneous low cortisol below 2 and had an elevated endogenous ACTH level, you can then do a calculation called the cortisol to ACTH ratio, or the CAR ratio, CAR. If it's less than 0.01, that calculation, look at how nice your specificity and sensitivity in to telling you that patient does in fact have Addison's disease. So here's a way that you could work around doing an ACTH stimulation. You could consider doing on the same platform in-house, serum cortisol, it's low, then run a plasma ACTH, it's high, do the CAR ratio, less than 0.01, you have an Addisonian patient. You can move right into therapy. So I think that's pretty cool application of this machine as well in our clinics. Let's move away from cortisol. Look at the fourth thing on our list now, serum TLI. This is the only test right now that the platform doesn't do for us. And a matter of fact, no one has a platform that does TLIs in-house or in clinic at this time, but hopefully it's coming or we wouldn't be talking so much about it. Nowadays, you will still have to send out TLI samples to a laboratory if you found that you didn't have Addison's, if you didn't have vitamin B12 or folate issues. And again, this is going to evaluate our digestive ability, our exocrine function for the pancreas. Really nice paper just written by Dr. Cridge and Williams talking about exocrine pancreatic insufficiency in dogs and cats in JAVMA this year already. So I'll just go ahead and highlight what happens to patients when you see that tremendous atrophy like you see in this poor surgical patient, has virtually no pancreas there. And on histopath just does not have the normal acinar anatomy. Exocrine pancreatic insufficiency occurs in both dogs and cats. I'll give you some cat data in a second. And again, basically, if you don't have digestive enzymes being produced and secreted, you're not going to digest your food. And if you don't digest it, you don't absorb it. Again, affects a variety of different breeds in dogs. German Shepherds are the ones we always think about. And it's been proven to be genetic in that breed. Tends to be a younger onset when we have congenital or breed predilections. Also, Lassie here, the rough-coated collie. Cavalier King Charles, what don't they get? Cairn Terriers, Chows, Cocker Spaniels, Westies, and the Erasure dog are all ones that have been proven to have genetic predispositions at younger ages to exocrine pancreatic insufficiency. However, we see it in any breed, in dogs and in cats, because as they get older, if they have chronic pancreatitis and destroy those acinar cells, the young guys tend to get atrophy. The older patients tend to be a destructive process from pancreatitis. And in theory, if you had a pancreatic duct obstruction, so the enzymes couldn't get out of the pancreas from either stones or masses, you could also develop this. That would be quite uncommon, but it has been reported. Oh, there's my Erasure dog, just as a little inside joke. I didn't know what they were. I looked them up, and this guy has got his eraser on the chalkboard. So with EPI, basically, again, your pancreas makes all the digestive enzymes you need to break down all three of the big categories of nutrients, fats, carbs, and protein. However, you have a lot of reserve in the pancreas. You have to lose over 90% before you'll get clinical signs of disease. But again, if you lose more than 90% of those enzymes, you can't digest, you can't absorb. It's not broken down to properly absorb across enterocytes. And again, you don't produce intrinsic factors, so you will automatically become cobalamin deficient, and you have to recognize and treat that as well to get better. And with all of this going on, we have tremendous microbiome disruption in these patients. So if they're not getting better, we also have to think about what their microbiome's doing and how we can help it as well. In dogs, when you have that lack of nutritional absorption, especially with fat, you tend to get that large volume, loose, voluminous steatorrhea. You'll see here in cats in a second, it doesn't always look like that. But again, that's just because of the high fat content that's in those feces. What about cats? Just to take a look at that. They said dogs tend to have that big malodorous, voluminous steatorrhea, and they tend to eat a ton. I mean, they can't eat enough because it's just going right through them. Cats are a little bit different. And this is really cool. When I was a young intern in New York City, I was there in 1987, 88. So this paper was published after I left. But in 1992 to 2007, at the Animal Medical Center, they only saw 16 cases of EPI in cats in that 15-year period. However, in 2012, when Texas A&M was really cranking up their GI lab and getting lots of serum samples sent to them for GI blood panels, they were able to identify 150 cases in a 15-month period. So it tells you there was a disease that we were overlooking. Why? Because it doesn't look exactly like dogs. These guys and cats tend to be older because it's not congenital or not inherited. They tend to have weight loss, number one. Stools are only malformed in about 60+% of the patients. They tend, however, to look sick, right? They get poor hair coats, chronic wasting of their body, weight loss. And again, only about 33% actually move on to watery diarrhea. So it just looks a little different. It looks more like lymphocytic plasmacytic enteritis or diabetes or some other disease in cats. One thing cats do get, though, is they do have a lot of fat in their stool. And sometimes if you look in their perineal or anal area, as they lick some of that fat into the hair coat in those regions. They can appear really greasy around the perianal area and the tail. But bottom line is it's a real disease, and we as clinicians need to look for it in cats. When I was a young veterinarian, guys, this is what I had to do to find it. I had to go in the dark room, take x-ray film, put poop on it, and then basically if it ate through, you see the clear areas there, the white, that told us the patient had trypsin. Thankfully, we don't have to do that anymore. We've now got actual species-specific assays that can look for basically trypsin and trypsinogen concentrations. Again, a simple blood test, serum sample. Just so you know, if you have a patient on pancreatic enzyme supplementation, you can still run TLI levels. It does not cross-react. Low TLI levels are pretty sensitive for the EPI diagnosis. I'll show you that in cats and dogs in a second. But there are some things that can actually increase TLI, such as if they had concurrent pancreatitis. or if they had renal disease. So again, you could potentially have a cat with CKD and EPI and have a normal TLI level. Or you could have a dog with chronic pancreatitis and they're losing terrible weight. They look like an EPI. Their values are normal for TLI. Again, those diseases can artificially raise the level. Reference ranges vary a little bit by labs. You'll still have to send these tests out to, again, either Antec or IDEX or the GI lab. Bottom line is if you're really, really low, you can see here dogs and cats, real low in dogs, 0 to 2.5. That's diagnostic for exocrine pancreatic insufficiency. Cats go a little higher, 0 to 8 micrograms per liter would be diagnostic. Dogs, when they're between 2.5 and 10, we consider 10 to 50 to be normal reference interval. It suggests that they may have this. You can either wait a small period of time and repeat the test, or you can go ahead and treat them and see if you get the appropriate response. The same for cats. If they're below 12 to 80 is basically the reference interval, but they're not below 8, it certainly suggests they could have the disease. Either repeat the level in a month or so, or again, just go ahead and trial treat and see if they do in fact respond. Okay, just a couple of comments real quick on pancreatic enzyme replacement therapy, or what we call PERT. A couple things. Bottom line is make sure you're using therapeutic concentrations of pancreatic enzymes, so they have to be RX forms. There's a lot of over-the-counter digestive enzymes that contain lesser amounts of enzymes. You're going to have failure. We want you to make sure you use the concentrated pharmaceutical brands like Pancreazyme on the veterinary side or PancreVed tablets, VialCase on the human side. We would prefer that you use powders instead of tablets. Powders seem to be able to digest food more appropriately in the GI tract, where tablets sometimes don't break down. You'll sometimes see a dog poop them right back out the other side. These are not inexpensive products, unfortunately. Some clients have difficulty, especially in really large breed dogs. If that's the case, there is a company in Canada called Enzyme Diane. You can see the website there, Diane, or the email. They do sell them and will ship them into the US, and they are a bit less expensive, especially for bigger breeds. Sometimes cats won't take the powders. As you know, cats are finicky and they don't like things mixed in their foods. When that is the case, you can go ahead and get Creon, which is a human brand of pancreolipase. They come in capsules that you can then open up. They're tasteless, little balls inside there, and you can better mix those in foods. A third of a capsule mixed in the food with each meal for cats is oftentimes something that we'll use if they won't take like Pancreazyme powder. Dose is pretty standard, 1 teaspoon per 10 kilograms per meal in a dog, 1 teaspoon per dose, again, in a cat for a meal, or the Creon. Another thing is sort of a tale of yesteryear. Pre-incubation with food is not needed. You don't have to put enzymes in food and let them sit for 10 or 15 minutes before the patient takes them. You can go ahead and put them in the food, feed the patient. They will do the job they're supposed to in the intestine. If the patient doesn't respond to what you're doing, increase the dose, usually by 25% increments. And if a patient's doing really well and you want to try to cut the cost down, you could try to decrease the dose in 25% increments to see if it's still effective. Another important thing is anytime you get a new bottle or a new product, you may recognize that the stool doesn't look the same and you may have to adjust the dose, because each batch of these, when they're made, is always going to vary a little bit in their actual enzyme makeup content. Just a couple more things about PERT therapy. Some patients, because this is a digestive enzyme, if it sits in the mouth, it can create erosions. It can actually digest your mucosa. So you can get lip lesions or palate lesions. This is one reason why cats sometimes really don't like the powders. If that ever happens to you, you can certainly go ahead, or if you just have a poor clinical efficacy when you're using them, or the cost is too high, there is one other little trick you can do. You guys can put this in the comments or questions and answer if you know who this gentleman is over on the left side. from an old TV show. But you can go down to a butcher. There's a hint for you. And you can oftentimes get them to save fresh pancreas from cows or pigs. And an owner can then take it home, and basically 1 to 3 ounces is 30 to 90 grams of frozen. They can basically chop it up into little increments. They can make little baggies and basically put 1 to 3 ounces in there. And that replaces 1 teaspoon of the powdered pancreatic extract. So again, this is a way sometimes that we can give it where a cat, for example, might really like to ingest fresh frozen pancreas from a cow or a pig. Okay, and there it is, just on a plate, and you can just chop it into little pieces, freeze them based on weight, and then appropriately give them to replace the pancreatic therapeutic extract. One other thing, guys, about EPI and its diet. Everybody always thinks because there's so much fat coming out of their back end, they're not digesting fat, that we should somehow restrict fat in these patients. Don't do that. They should be on regular maintenance diets that are complete and balanced and have normal fat content. If they're still producing lots of fat in the stool, we're just going to give them more of their pancreatic supplement. But you can fat malnourish these patients if you restrict them, because they're already having trouble getting it in. You're never going to get back to 100% normal absorption, so don't fat restrict. Okay, I'm going to skip these other things that are not all that exciting. So pancreatic specific lipase is the last thing we'll talk about tonight. And this is lipase that originates only from the exocrine pancreas. It goes ahead and enters circulation when there's any active pancreatic damage or necrosis. We recognize you can have either acute pancreatitis, where you might release a lot of pancreatic lipase, or you may have chronic pancreatitis in patients where you're not turning over or releasing as much from damage or necrosis at those times. How can we use this test for us? Just want to make a couple of comments, because there's been so much in the literature and so much debate back and forth about tests and what's available and how to interpret PL tests. When you look right now, there are 2 different types: the immunoreactivity assays, which are specific based on species antibodies. We know that SPEC PL, which is IDEX and Texas A&M's licensed product, was the first one that came out. It's always been looked upon as the gold standard. They, of course, at IDEX have a SNAP test for bedside, which is semi-quantitative. VetScan also makes a canine pancreatic lipase, which is semi-quantitative for in the clinic. BioNote and the Truforma machine both can do quantitative in-clinic point-of-care pancreatic lipase testing. And those are the ones, again, that you can see in these pictures. Now, Antec, if you're an Antec customer, uses a non-immunologic colorimetric assay called the DGGR assay. I dare you to say the actual name of it. It's quite a mouthful. And that one, again, is a different assay, but performs pretty closely to the immunoreactivity assays. So what have we learned over the years? I'm going to try to make this really simple for everybody, because, again, I think it gets so confusing. But what we know is basically a number of facts, and I'll spell those out for you after 20 years. Immunoassays are definitely more accurate. So again, if we're looking at accuracy, although the DGGR is close, it's not perfect. The SPEC PL is considered the gold standard, again, at IDEX or A&M. However, it's not the gold standard for pancreatitis. You'll see it does have issues with sensitivity and specificity. The actual gold standard is a pancreatic biopsy, but none of us are going to do that in a clinical case. There's been some publications that are basically in conflict with each other as to how good these other tests are in comparison to the SPEC PL. The bottom line becomes, if you have moderate to severe pancreatitis and you're a dog or a cat, then it's going to basically have pretty good sensitivity and specificity, and positive and negative predictive values to make a diagnosis of pancreatitis. Where we have trouble is in patients with less severe disease or chronic pancreatitis patients. The SNAP test is nice as a point of care, but it does have reduced specificity, meaning there's a lot of false positives with SNAP test because it turns positive at 200 instead of turning positive at 400, which is where we consider sort of the cutoff for pancreatitis. So the question always becomes, is a pancreatic lipase test good enough to diagnose pancreatitis? And I think the answer is still no, it's not. Here's what we basically know statistically, is that if you have a PL test, we're going to take dogs in this example, but cats are pretty much the same with their values. In dogs, if you're, whatever way you run this test, if it's less than 200 micrograms per liter, it's an extremely sensitive test and has a negative predictive value that no matter which test you use, it's about 100%. Means you can rule out pancreatitis. If you get a positive over 400, so it's got to be quantitative, over 400 micrograms per liter, you can see it definitely improves the positive predictive value, but it's nowhere near 100%. And so again, in summary, a normal pancreatic specific lipase under 200 in dogs is very reliable in ruling out pancreatitis or a negative SNAP test, where an increased pancreatic lipase by itself, you have to look for other factors that are consistent with pancreatitis. You've got to have appropriate clinical signs, appropriate imaging findings, possibly appropriate cytology if you did a fine needle aspirate, or a biopsy if you did it, in order to very much then say, I have pancreatitis. The PSL value alone doesn't tell you that. So bottom line on pancreatic lipase, guys, trust the negative. If it's low, you don't have pancreatitis. If it's high, verify it. Look for other things that also are in line with that diagnosis. It's like taking a jigsaw puzzle and putting enough pieces together that you can then trust that value. Okay, so that's all we'll say about that for tonight. So let's finish up, guys, because we're right on our time deadline here, and just give you a couple of minutes about this TRUFORMA machine and how it works and what sets it apart from some of the competitors. It's an interesting machine in the fact that it's a bulk acoustic wave technology. So it's not your typical chemilucence or radio immunoassays that you've grown up and become accustomed to in veterinary medicine. Simple operation. I mean, even I can run the darn thing. But it is really cool. It has Bluetooth capacity. You can play tunes on it while you're waiting for your results. So it's a multi-platform for sure. It's expandable, meaning there's tests being added to it all the time. Bulk acoustic wave technology is something that is inexpensive, and it's in common things. It's in cell phones. It's in airplane electronics. There's so many applications for this technology that it's become quite affordable. And I think as far as Zomedica goes, there's no contract obligations if that's important to you from a laboratory standpoint. So what is bulk acoustic wave technology? It's pretty cool, actually. Basically, with this machine, we're going to basically put our fluid, which is usually serum or plasma, into the machine, and it's going to flow across what's called a bulk acoustic wave sensor. And I'll come back to that, and then, of course, the remainder of the fluid will flow out. So it's a cartridge-based system. You plug the cartridge in, put in your sample, and within 15 minutes for most of these tests, you'll have your results. How is this different than radio immunoassays or chemilucence? It doesn't require fluorescence. There's no light optical things to read. So there's no real interference from lipemia or hemolysis. What bulk acoustic waves means is there's a sensor plate, which you see down here at the bottom. And this is a sensor plate, and think about it. They can put an electrical charge across that. So that's our signal in. We've got a signal that goes in and charges that acoustic wave sensor, and that will start to vibrate or oscillate at a certain frequency. Now, as our analyte washes through, that sensor has been impregnated with antibodies against whatever we're trying to sense. So we bind, whether it be cortisol, or we bind cobalamin, or we bind pancreatic lipase to those antibodies attached to the sensor, and that weighs it down. It becomes heavier. And anything that is oscillating or vibrating, if you weigh it down, it will change the frequency. And that frequency is then sensed, the change in it, as the signal out. And through mathematical calculations, this machine can then determine how much T4, how much cortisol, how much pancreatic specific lipase, cobalamin have we bound? And that can be then, basically reported out as a milligram per liter or whatever the indices or reference ranges are for that. So what's this comparable to? Again, most laboratory things are done on a Siemens Immunolite 2000. That's the kind of state of the art or the gold standard. You can even see it's got a halo over it if you look at it right there. That's only going to cost you about $150,000 to put in your clinic. Probably not something most of us are doing, unless you're running one heck of a lot of lab samples. You can put this machine on your countertop. It's the size of a shoebox. And again, it has very simple, no reagents for you to mix or mess with. You just plug a cartridge in and apply your serum or plasma, whichever is called for that analyte. And basically, again, it's going to flow through that. It's going to be bound to that resonating plate, and it will change the signal so that we can interpret what we have. So right now, today, we've been talking about gastrointestinal applications. So pancreatic specific lipase, cobalamin, folate. The cobalamin folate actually comes in one cartridge, so it can read them both at the same time. So that's great applications for your GI patients, as we've just gone through tonight, and hopefully, how you diagnose these and then how you treat some of the ones we've talked about. This machine, again, is a multi-indices platform. It's also a great endocrine machine. It can do total T4 for dogs and cats, TSH for dogs, also optimized TSH for cats, meaning you can get down really, really low to help you with both hyperthyroid diagnoses when it's hard to diagnose, but also in monitoring hyperthyroid therapy. It does free T4s. It does cortisol levels. It does endogenous ACTH, both for dogs. And if you are a mixed animal or an equine practitioner tonight, it does equine ACTH as well. So again, I'm happy to help support this platform. I'm not going to go into a lot of the specifics tonight. This is where I last gave this presentation, is Las Vegas. So this is the Sphere if you haven't seen it. I won't go into a lot of details tonight. There's great white papers out that show the coefficient of variation and accuracy of this machine compared to the Immunolite 2000. They've been very, very good. But even more so importantly, many of these assays are now being independently validated. Michael Lappin at CSU, Mark Peterson in New York City, the endocrine guru, Jackie Whitmore used to be at Tennessee. A number of these clinicians have all taken on and done independent validation of these analytes. So it's a great machine for you to consider. And I think this evening, as long as you tell them my name, if you talk to your representative, you can get the machine for free, and you just end up paying for the test cartridges. So a pretty cool deal for you there as well.